Requesting Dr. Raman Mittal to present his topic, droopy eyelids, what all to look in for.
Good evening, ladies and gentlemen. I see that most of the people are enjoying outside, but whosoever is inside, let's dwell upon the droopy eyelids, which is ptosis. And we all know about the normal ptosis which we have, congenital and aponeurotic ones. But in this presentation, my interest would be to discuss with you all what all other factors and what all other things which you need to see in cases where the patient presents you as ptosis, but there are so many other things which can mimic ptosis. So by ptosis or by droopy lids, it is drooping of either one or both the eyelids, which could be present congenital or acquired. These are the workup schedule which we all know that we need to work up on fissure height, margin reflex distance, crease distance, LPS section and whatnot. And the surgical procedures also, for depending upon what procedure is done, depending upon what findings we have, we decide upon the procedure. But here, apart from congenital ptosis, which is normal, we see poor LPS section, moderate to severe ptosis, you go in for sling surgeries. Here, if the ptosis LPS section is good, you do LPS resections. Acquired ptosis, senile aponeurotic is still the commonest, which you face like this. It could be an aged gentleman. This was around 90 plus, and within 2 weeks he is doing so well. So all his forehead lifting and this thing has gone. So now I will discuss this. All we know. So I have just brushed it through. Now what we want to know is the variants or the changes which we have in the droopy eyelids. Like a ptosis patient may present with double elevator palsy. So once you lift the lid and see the globe, you may see that there is hypotropia along with the ptosis, and there is superior movement restriction. So in these type of cases where there is a hypotropia, you first need to treat the hypotropia and then you treat the ptosis. Otherwise, the patient will not be happy and your thing would remain undercorrected. Marcus gun phenomena is another important association which may have with ptosis, and sometimes I myself am not convinced about disinserting the LPS of both the lids and doing sling surgeries just in case to correct the Marcus gun. My take is once you correct the ptosis, Marcus gun anyway reduces quite a bit. So if you counsel the patient's attendants well, that it will be reduced if not completely gone, but we are not touching the normal eye, they are convinced, and you should take care of that. This I have kept it as a variant of ptosis because not only there is a drooping lids, but there is decrease in the horizontal fissure width as well. So if you have a high suspicious index, you should measure those horizontal fissure as well, and you should correct them along with or before doing the vertical correction to give a good result, as we see in this slide. Sometimes we have a normal ptosis, but here in this picture what we see is that there is an inferior scleral show. So this inferior scleral show was well documented and was well discussed with the patient beforehand, because after I corrected the ptosis, they were saying that this is overcorrected, but actually this is not a case of overcorrected. If you see the upper margin, the upper eyelid margin, they are well in place, but because of the inferior scleral show, it is looking like it is overcorrected. So I had to, most of the times it gets corrected automatically, but in this case I had to correct the lower eyelid as well, and after the second stage surgery she was perfectly fine. We also know about the variants of ptosis in cases of myasthenia gravis and CPEO, which is chronic progressive external ophthalmoplegia. Sometimes it could be a neurogenic third nerve palsy which present to you as ptosis, or droopy eyelid, could be traumatic or mechanical. I'll be discussing few cases. Myasthenia, we all know there is variability, there is generalized weakness of either ocular muscles or other body muscles. Sometimes they are only 15% of they are purely ocular, others are general myasthenia gravis. There is fluctuation of the drooping, there is worsening of ocular symptoms as the patient is doing reading, watching television or driving and all. So worsening of jaw muscle on weakness and all that stuff. So worsening factor is there on exertion or in getting fatigue. Here looks like a simple case of ptosis, but actually she had ocular myasthenia gravis. So in ocular myasthenia gravis, the patient may present to you with only ptosis or may have even diplopia may have even inappropriate closure of the lids. So there could be an orbicularis weakness as well. Of course, we know that anti-acetylcholine receptor antibodies, tensilon tests, electromyography, and ICE test, which is very important, very easy to do in the office, is there. So management, we can go with medical management or ptosis crutches if we know. Once the patient is not improving with all this, sometimes you actually need to resort for surgical management also. In diplopias, you can do patching and prisms and all that stuff. In CPO, where it is not improving with medical management, there is restriction of the movements. You can give crutch glasses to manage this patient, and then you can lift the eyelids. But sometimes I have started doing surgeries after doing a proper counseling with under correction, so that just to spare the pupils so the patient can see. Third nerve palsies, again we have to lift the lid, see for the movements, look in for the history. With conservative management they get well. Like in this lady, she was absolutely corrected. So I'm just keeping this as variants because sometimes patients present to you with drooping of lids and we jump into the conclusion because the referring doctor would have also mentioned ptosis and you jump into the conclusion of doing ptosis corrections, but it's not the case. And this is a very interesting case because this presented as an acute onset or a sudden onset drooping, but there was a myocysticercosis on ultrasonography. So with the management, medically of course we know she corrected well. And similar was this young lady who had inflammatory signs as well as severe ptosis, but she was absolutely corrected after 1 week of management. So we have to keep all those things in mind. That's what I'm trying to suggest. This patient who was referred to me as congenital ptosis actually also had enophthalmos with poor movements in all the gazes. So I got her investigations done. Her scan showed that she had very atrophied muscles. So I was not dealing with a simple case of congenital ptosis, but it was a case where the muscles were actually not developed. And you see in the picture below that she is not having movements. So first I counseled the parents well and then planned to do an enophthalmos correction, and then after doing the enophthalmos correction we did the ptosis correction. I think we have some speakers not there, so we can continue. Thank you.
Talk one. Sometimes we are talking about the myasthenia in CPO. So I am also doing now the surgeries. And what type of surgery you will prefer?
Okay, that's a good question. If there is absolutely zero LPS section, okay, because the movements are not there, difficult to calculate the LPS section. If there's absolutely no flick in the LPS, then I sometimes resort to doing sling surgeries. Why? Because sling surgeries, you have a better control on what lift you want. But before that, I would check properly the orbicularis section. If the orbicularis section is good, only then I would go in for a ptosis correction surgery. If the orbicularis section is also weak, I will not go in for a ptosis correction surgery. If I see a flick of LPS, but there is also movements are there, it's not total frozen movements, then I would go in for an LPS. So I have done LPS as well as sling surgeries with good results in both.
I have a question, sir. I think sling surgery will be better because if there is exposure post-operative and not corneal, it is very easy to remove it and reversible.
Yes.
Agreed.
We can achieve.
The
And
problem
the LPS
is
will be, sir, again you have to open and
generally if you treat them well, if you counsel them well and you keep them under your scrutiny, they'll land up into complications, I agree, but they come up well also. In sling surgery, another problem which I find it, because it cuts through the tissues and the muscles are already weak, sling ultimately gets loosened up. So that is another issue, you know. And nocturnal leg ophthalmos is much more severe in cases of sling surgeries, and these guys already have poor bells. So that's why that's a gray zone. We all need to come to a conclusion. Yeah, Dr. Neelam, yes. Try to lift.
But still, you can. There's a direct mechanical lift. Get me, yes, yes. Not only I will explain, but
Yeah. When I say sling, I mean silicone sling. I am not doing facial ATAs anyway. So, but
Yeah.
yes, your point is well taken and very well explained.
Yes, yes,
Yes,
yes.
yes.
Always. That's why I'm asking his
Mm.
question. Yeah. So always silicone. I always prefer.
Mm.
If you are doing the fasalata, in fasalata for a normal people is okay.
Mm.
There is a adhesion. There is
Mm.
a it is a normal tissue. More reaction. There is a adhesion inside. So there may be a more injury on that muscle. So there may be a more lag of thermus, etc. also. But in silicon, there is a elasticity, good quality elasticity. One advantage is a mechanical plus elastic mechanism will work. And I don't have any such courage to go for a almost full correction, or I am just
Absolutely not.
slowly, very minimal, just up to that, just people, just a,
Mm.
just pupil.
Quite
Too
undercorrected.
too
So
much
just
undercorrection for sure, for
bear
sure.
this pupil and they do well. So in
And
this case, I did inophthalmos correction first, and after doing the inophthalmos correction, I placed an orbital implant. Okay.
please, madam, please tell. What your question?
How did I do the
Okay,
orbital?
okay, madam.
So in this, I placed orbital sheets below the globe. So that lifted the globe from behind. So that corrected the inophthalmos in this case. I already explained the patient, she already had a frozen globe. So movements won't be there. So once the inophthalmos was corrected, there was only a slight correction in the ptosis. In this case, it was not a very good correction, which we would see in the traumatic inophthalmos cases. So this was her picture after inophthalmos correction. So once inophthalmos was corrected, then I did ptosis correction. Why I did inophthalmos correction was the reason, because if I would have gone for ptosis primarily, one, I would have to do overcorrection because there was an underlying inoph. Secondly, she is a girl and she would become marriageable age then, and inophthalmos would always keep on bothering her because the eye would be looking like sometimes sunken than the other eye. So in this case, the thing was only cosmetic, and to achieve a proper cosmetic, and if I do a ptosis first and then do an inophthalmos, again it will change my variables. So inophthalmos correction was the first one which was decided by doing orbital implants. I did a double sheet, if I am not wrong, if I am remembering, 1.5 millimeter thick Porex sheet that was placed in the orbital floor. 2 slices, and then I did Porex. So in this, the mechanical ptosis, because of the capillary hemangioma, again the patient was referred as congenital ptosis, but on seeing the patient, on everting the lid as drawn in this diagram, patient actually had an underlying capillary hemangioma, and once you conservatively manage the child, it got better, and you see that the ptosis was corrected. In this lady, again, the patient came to us as a case of acquired ptosis, a middle-aged female. On first look, she looks like either a case of ptosis or a case of retraction of the other eye, because we see that the margin is there on the upper or the superior limbus. But on everting the lid, once you open the lid and see, there is a salmon patch-like appearance underneath. And you see this, that was to be corrected. So she got fine after doing that correction. And similar, this case, the child never gave a history of any trauma and all, but on everting the lid or opening the lid, you see there's a huge lesion below the lid, which is actually adhering to the undersurface and causing ptosis. So it was a case of pseudotosis, and once I excised that lesion, the patient's ptosis got automatically corrected. I did not do any ptosis correction for this child. Of course, we know that microcorneas patients sometimes present with ptosis, either unilateral or bilateral. We need to tell them about their condition, that the underlying eye is at problem, and in these type of cases, you need to do a ptosis correction, having looked that the cornea would be smaller again. Thyroid orbitopathy has been discussed, but sometimes the patient may present to us with ptosis with full movements and all. So here, after doing all the medical conservative managements, sometimes we need to do surgical corrections, either doing LPS recession as the previous speaker explained, or even LPS elevations. So here it was a case of retraction who was not managed, who could not be managed conservatively. So I did LPS recession for the patient with a good cosmetic correction later. Thank you very much. So all these things are like we can have asymmetry of the lid height. And ptosis is not the only diagnosis, but there are so many other things which we should keep in mind.
Raman, in case of a capillary hemangioma, what is your
Propranolol, 2 milligram per kg body weight in divided doses.
yes, that is the very effective propranolol. And are you start from your own, or you are taking some help from others?
I actually my brother is a pediatrician, so
Easier for you.
it's not easy for me because convincing your family members are difficult.
Yes.
So I took help of a pediatric cardiologist. I took help of pediatricians, but they are very negative about it.
Yes.
They don't want to take the onus on them. So you have to explain to the parents that nothing happens to them. You can start with the minimal dose. There'll be 10 to 20% of the patients or the parents, I would say, who are not convinced because they would go and Googleize, and Google would tell you that there's so many things. But in a span of my experience of more than, I guess, now 12 years that I'm doing propranolol, and even I have given it for few months old children, nobody has any problem. And disclaimer is that I myself use propranolol for the last 3 years for some tachycardia condition, and my daughter is also using. So I have seen personally that apart from that it reduces the heartbeat, bradycardia is of course, nothing else happens. And of course there's a withdrawal effect. So once you have to finish off, or you can say stop the treatment, don't stop it abruptly. Just do it tapering. So that is important. I have realized myself over the period of time that once I do tapering, then the patients behave well. Otherwise they may have some palpitation and tachycardia complaints. In kids it's not so much, but yes, it is possible, but no complication or side effects.
Propranolol even ointment also now, I think some kind of glaucoma people are using some ointments. We can use it.
Timolol is something which we give for local, like in conjunctival capillary
What?
hemangiomas, we give timolol, timolol gel types. I have not come across propranolol ointment. Do we have?
No, that timolol.
Timolol, yes.
Glaucoma,
Timolol, yes, of course. Beta blockers.
Beta blockers. And just I always advise my that children, instead of, if you are sending to the pediatric cardiologist, generally very few are tuned with the pediatric cardiology, and most of the time they are echo are done by the diploma holders, and the DM is mainly looking at some high halo. That's the reality. That's why I always advise straight to echocardiography and ECG to compare the heart rate. Ask the sister to see the pulse. If the pulse is more than 76 or 80, you are very safe.
Generally it is because the kids anyway have tachy.
Yes, tachy. Most of the time
that's a normal thing for the kids to have. They are anyway having a higher pulse rate.
Most of the time there is a 90 or 80.
And to be on the medical legal safe, as you say, I definitely write in consultation with pediatrician, though I may not convince them hard to go to a pediatrician, but I write it so that I can budge on it, that I have told them, they have forgotten it.
Or sometimes I started myself and asked them to consult local pediatrician after 15 days.
Yeah.
Safeguard.
So that's the way. Well, we should be keeping ourselves medical legally safe. We have to write it. I mean, institutes where in the house, how convinced they are to start propranolol for younger kids?
No, they are.
Yeah. Most of the time what I have seen is they will tell us telephonically, yes, you can go ahead. They will not write. In my practice, I have seen most of the times they will say nothing will happen, go and get it started, but they will not write it, okay, yes, it is safe to start. That's what I have come across, at least in private practice.
But in private, I am also right now doing private practice. I am just telling particularly doctor with that institute, with the special note, need that one, and telephonically convince them. And this is technically is very difficult if there's something happen. And ask the parents to purchase a pulse oximeter at least at the home. They can check every day. I ask to every day, and every 7 days you just send me the reports of the pulse.
That's a good idea. I guess that can be done easily.
It's a good practice in private practice. Okay, madam, please.
Yes. Yes, I've done because, see, if you see that the LPS section is poor, you decide that you're going to do sling. So it's a fixed thing that you are going to do it. So now when you are correcting the hypotropia, once the patient is under general anesthesia, it's the only purpose that you're bringing the globe to the centric position. The LPS section is not going to change. The excursion of the lid, the previous, before surgery, after surgery, doesn't matter if you're doing sling surgery. It is what you leave on the table. So if you have that type of condition, you can easily do it. I have done in few cases. Anyway, in sling surgeries, they tend towards undercorrection, or even in severe congenital surgeries, ptosis surgeries, undercorrection is the rule. So you have to overcorrect. It is a very well documented rule that congenital ptosis with poor LPS section, they are going to fall into undercorrection category. So overcorrection is the rule. You have to overcorrect, and if you have it so soon, you'll revise the surgery.
Just I add one point, please sit, one point with. So suppose you overcorrect it and in over 6 months again undercorrect, because that person is, if there is a unilateral, they are not using the one side. So before surgery, you just tease him or her to elevate the eyebrow, because we are implanting something here only. You have to lift up your by its own. You just explain it, then it is very successful. Anyway, whatever, after 3 to 4 months there is a drooping. That's why the rule of the thumb is always sling. In case of unilateral, you have to overcorrect it. You should be mentally ready to face all kind of corneal exposure on that particular 3 month only. That's why that penthizol or whatever lubricant is generally for 6 months at least minimum. Then it's generally droops.
Any questions further? Thank you so very much. Nice to have such an attentive audience.